The thing is, with bariatric patients, they are at a high risk of marginal ulcers. So these medications that seemingly are easy, benign, our go-to can cause some serious complications and we can impart some serious harm on these patients.
Welcome to the Evidence-Based Urgentology podcast from EB Medicine, where urgent care meets evidence. I'm Joe Toscano, Senior Research Editor for Emergency Medicine Practice and a member of the Evidence-Based Urgent Care Editorial Board.
Hi there, and I'm Tracy Davidoff. I'm Editor-in-Chief of Evidence-Based Urgent Care, and we're practicing urgent care physicians with years of experience, probably too many years of experience, on the front lines. And for us, diagnosis is detective work, and the clues are in the history, the exam, and of course, the evidence. That thrill of solving the patient's puzzle is really what keeps us coming back.
Each month, we unpack the latest issue of Evidence-Based Urgent Care, tackling common chief complaints from presentation through diagnosis to disposition. We highlight the best evidence, the key takeaways, and the clinical pearls.
And by the end of every episode, you'll have sharper skills, deeper knowledge, and more sound strategies that you can use on your very next shift. So let's dive in. The evidence starts now. And remember, you can always find more at www.ebmedicine.net.
Hello, everybody.
Y'all know who we are. Joe Toscano and Tracy Davidoff here. We're going to talk today for our podcast. First, though, we want to give you some promos. Got to pay the dues, right? The first one we have is some information about a new promo, which is a podcast exclusive. If you use promo code PODCAST, PODCAST, you'll get 15% off your subscription to everything EB Medicine. And then they'll also throw in the Points and Pearls year in review for 2024 and 2025. It's a $795 value, and it highlights key insights from the past 2 years. We rolled back our pricing to reduce barriers and make trusted evidence-based education easier for clinicians to access. And if you'd like to see our new pricing, go to ebmedicine.net/subscribe.
Some good deals there for sure.
Exactly. What are we talking about today, Joe?
This month, we're talking about the August 2026 issue, which is on the urgent care management of the patient with prior bariatric surgery. We are honored and delighted to have the author with us. We always love doing this versus just the two of us talking, although you're great to talk to, Tracy. Our author is Melissa Thomas, PA. She's actually the Medical Director of Quality Assurance and Performance Improvement for WellNow Urgent Care in Syracuse, New York. Welcome, Melissa.
Well, thank you. I appreciate you having me here.
Thank you for being willing to talk to us. This is always fun to get the author on.
Absolutely. Today, we're talking about bariatric surgery complications. If you read the article, it goes over some of the certain procedures that are involved with it and some of the things that are likely to show up in urgent care that the urgent care clinician really needs to be aware of and really needs to keep an eye out for. One of my biggest things with this is that people are not always forthcoming with this diagnosis or this previous history. I'm not really sure why that is. I don't know. Maybe there's still some stigma about it or some stigma about obesity, or maybe it's been so long that some people forget. It's really smart to stay diligent to this and to ask people. When I start talking about NSAIDs, which we'll talk about a little bit later, I always ask any stomach problems, any peptic ulcer, any renal disease, and then I always throw previous weight loss surgery in there. And you'd be surprised how many people will tell you that's the case when you didn't even suspect it. So I'm passionate about this. I actually gave a lecture at UCA about this, I don't know, maybe 7 years ago. Nothing's really changed all that much, except that the laparoscopic procedures are getting a little more common. But what people show up for in the urgent care with the complications is not really changing all that much. Like I said, I have an interest in this, but Melissa, I'd really like to know why you have an interest in this and why you thought that it would be good to write an article about this for EB Medicine.
Well, first and foremost, urgent care is the first stop for a lot of patients, but certainly the bariatric patient. Post-bariatric complications, these can hide in very routine complaints. Most of these patients aren't calling their surgeon at 7 p.m. on a Saturday night. They're coming into us and seeking our care. So common things, abdominal pain, nausea, vomiting, dehydration. We see these each and every day, but we need to recognize specifically in this patient population that this could signal something serious, something potentially surgical or even life-threatening. And it may not be, say, a routine gastroenteritis.
Yeah, that's a good point. We see nausea, vomiting, and abdominal pain all the time. And most people, if you just treat them symptomatically, you're probably not going to do any harm. But in these patients, it's a little more likely that you might miss the forest for the trees if you don't get that history or you're not particularly diligent about it.
You're absolutely right. Some of those symptoms are just non-specific, like nausea and vomiting, but you're going to perk your ears up a lot more if the patient's had a prior history of any surgery, but particularly bariatric surgery. Because these are more and more common, there are more people that are out there with it who can walk in our doors. And so it's super important for us to learn about this. And we're really glad that you did the paper. What's your biggest red flag, Melissa, would you say, when you know the patient has the history of prior bariatric surgery and you're evaluating them for a GI complaint? What's the biggest red flag for you in their evaluation?
I would say for all patients, first and foremost, vitals are vital. So tachycardia is one that I will frankly say scares me in most patients, but particularly in this patient population, specifically a tachycardia or persistent tachycardia over 110 beats per minute really should stop you dead in your tracks and say, hey, is there something more going on with this patient? Do I need to think about some real serious potential complications in this patient population? This is really the most sensitive clinical sign of surgical complications after bariatric surgery. So it's really important that we pay attention to this because it's a big red flag. And it can be our earliest sign of leaks, PEs, hemorrhages, or even bowel ischemia, sepsis. So we would need to not reason it away and think it could be something else causing it, like anxiety or pain even.
Mm-hmm.
Yeah, that's interesting. You made the comment that in any patient, you should really worry about tachycardia. And that is so true. There was I don't want to call it a landmark, but in my mind, it was the landmark article that was published in Journal of Urgent Care Medicine by Mike Weinstock about bounce backs. It was in regards to ED and urgent care patients. About 25% of those that you sent home with abnormal vital signs are subsequently going to end up in the emergency department on discharge if you didn't address that. So really super important. Vital signs are vital, absolutely. But specifically in these patients, that's even more of a red flag for you.
Yeah. And you said persistent too, which I think is important. Vital signs are vital. And I'll notice a lot of times when I go to examine someone and I'm listening to their heart, it's not as fast as it was at triage. And that's when it's important. You got a second point on the curve, but you got to make sure you document that. And if it's persistently fast, though, or getting faster, then there's your red flag for sure.
Yeah. Good point. Repeat those vital signs. If you get something that you're not happy with, always repeat it and confirm that it's accurate. And if it is accurate, make sure that you address it in some way, shape, or form. One of the other things with these patients is not all patients will have standard abdominal findings after they've had bariatric surgery. Can we talk a little bit about that, Melissa?
Yeah, this is an interesting set of patients because the core problem we face here is that physical exam is actually a poor rule out tool in this population. So really hanging our hats on a benign abdominal examination does not rule out a surgical emergency. Some of the things that can contribute to this, body habitus in this population really limits the exam itself. So with that limited exam, palpation, percussion, these are less reliable in these patients due to their obesity, independent of what may be going on inside. That localized tenderness or being comforted that there's no rebound here, great, no surgical abdomen. We can't be comforted by lack of these peritoneal signs because they're frequently absent, even in patients that have some serious intra-abdominal pathology. So we have to stop trusting that reassurance that a benign exam means this patient doesn't have something serious going on.
Do you think it's just because of the anatomy of the obesity, or is there something other at play here? We're talking about internal hernias, maybe because it's sitting posteriorly or behind things, and it might be a little more difficult. Is there a late finding that would develop into peritoneal signs? Or do you think there's anything that has to do with the surgery itself that might make that less likely?
Certainly in these patients, these findings can be quite subtle. And again, very notorious that they can have benign exam, even benign labs and imaging to go along with that. A lot of their symptoms may come and go. So really having a low threshold that there could be something serious going on here, we have to consider these patients are high risk and really have a low threshold for having those consultations or conversations with their surgeon.
One of my favorite things is pain out of proportion.
Yeah.
Or many, many different diagnoses. If the patient is telling you, in this case, this pain is really bad, and then you do an abdominal exam and it's like, not so much. That should definitely be a red flag to you that something's not right here. I need to look into this further.
For sure.
I agree. Just like the mom with the pediatric patient says something's not right. I tend to stop and really listen to my patients. I feel like that's one of the biggest things I've always learned. Is when somebody says something's just not right, dare I say, trust your gut here, you might want to stop, really double check your bias at the door and say, hey, maybe I need to dig a little further here or think about more things, cast that net a little wider.
Yeah.
Definitely.
These patients can get gastroenteritis or other kind of GI illnesses like anyone. What are some of the other clues that urgent care clinicians can use to distinguish between that simple stomach bug or a complication related to weight loss surgery, Melissa?
Some food intolerance is actually expected after bariatric surgery. It's quite common and it should be mild. But if it's not resolving or the patient truly can't keep anything down, including liquids, that's concerning. But persistent nausea, vomiting, and abdominal pain, these can be common and sometimes be benign. But I would say any patient with new onset abdominal pain or complaints, status post-bariatric surgery, can have complications until proven otherwise. If you throw in other things such as that tachycardia we discussed, any fever, tachypnea, persistent vomiting, or intolerance to PO, you really need to consider there's something worse going on here. Pain out of proportion, or they look sick, that feeling of doom, like something is quite wrong here or not quite right. It would be careful to pin it to something benign, such as a gastroenteritis. Doesn't mean these guys can't get gastroenteritis, but always have the consideration of the serious complications first and foremost. This isn't just reflexive IV hydration and a discharge. This really should be a full evaluation and discussion with a surgeon.
You didn't really talk about this in the article, but one of the things I like to ask when these people start telling me about vomiting, especially if they don't look as sick as I think they should, is I ask, what did you eat? Because a lot of times they'll go through what they ate and it's like, you really shouldn't be eating that. If you've had a gastric bypass, I ate 3 slices of pizza. Well, of course you're going to throw up. Your stomach is the size of a golf ball. You shouldn't be eating that kind of stuff. A lot of times when you start talking to them and you understand what's going on and what they've been doing, a lot of times they receive as much or as good education as they should have, or it's just been a while, so they think that it's now okay. Not saying that's going to be in every patient, but dig a little deeper about why they're throwing up. What did they eat? What did they try to eat? How long ago did they eat it? That sort of thing. And sometimes you can uncover some stuff just in there. So I read in the article that some patients with leaks may be super subtle. We alluded to this a little bit earlier. A lot of times the patients will have a sense. So patients that occasionally have leaks or will have some sort of peritoneal findings will tell you about some sort of feeling of impending doom. Can we talk about that a little bit?
Yeah, and certainly leaks require immediate transfer. We don't want to delay on this. But again, when somebody tells you something is wrong or this feeling of doom, this is a classic presentation of a leak. Certainly this dramatic presentation of abdominal pain, oral intolerance, something's wrong. This is pretty well documented, but most of the time it's more of the subtle version. And this is what we worry about that we might miss. So instead of that dread or dramatic pain with a leak, patients can have these subtle findings as we've discussed here. And really, again, we need to be diligent and really dig deep with these patients and make sure that we're not missing anything.
Yeah, definitely.
That feeling of impending doom, I find occasionally in PE patients too. For some reason, the ones that have a big, large volume of clot, it's like, I feel like I'm going to die.
Yeah.
Hey, Melissa, you talked about the number one don't miss complication of a Roux-en-Y gastric bypass. Why don't you tell us and our listeners about that?
So the internal hernia is the number one can't miss and most dreaded complication of the Roux-en-Y gastric bypass. These can cause symptoms that fluctuate. Pain can come and go. A lot of the time, patients may not have those abdominal findings. CT can be normal. Labs can be normal. So it's one of these we always worry about. Are we going to miss it? But we always have to be thinking about it and certainly looking for it in these patients. So what happens is postoperatively, that surgery creates some mesenteric defects and spaces that weren't there before. So you get closed loop obstructions, which lead to ischemia and necrosis. These can show up late after surgeries. They can be a long timeline after a procedure, so months to years after. Again, a lot of times we'll attribute it to benign things. Oh, it's maybe gas, constipation, gastroenteritis, and we'll be comforted with exam looks benign, labs are good, imaging is normal. These we worry about, we need to think about them all the time in these patients and always be looking for them.
Yeah, this is one of those things you really want the surgeon to make a decision on. If you have a high index of suspicion or even a low index of suspicion and it's on your differential, that's mandatory surgical consultation and not let's just sit on them in the emergency department or the urgent care.
For sure. Yeah.
My biggest pet peeve and why I would never have the surgery, to be honest with you, is because I love my NSAIDs. If I can't take my naproxen for my back pain or my shoulder pain or my knee pain or whatever, I don't know what I'd do because acetaminophen just doesn't cut it for me. But absolutely 100% in patients that have had this type of surgery, NSAIDs are a no-go. But I find a lot of patients are unaware or they think maybe I could just take a little bit, it'll be okay. And some clinicians really don't know. I see people that come back for workman's comp things all the time that somebody put them on diclofenac or something like that. And I look at their medical history because it's a comp injury. Who cares about their past medical history? You should care. So let's talk about NSAIDs and people that have had bariatric surgery.
This is a huge pitfall potentially for the urgent care clinician. Everything that we see in urgent care, this is one of those medications we instinctively or reflexively reach for. We see ankle sprains, we see back pain. It's easy to say, yeah, take some ibuprofen, naproxen. The thing is, with bariatric patients, they are at a high risk of marginal ulcers. So these medications that seemingly are easy, benign, our go-to can cause some serious complications and we can impart some serious harm on these patients. So really, we need to be aggressive about asking about past surgical history, thinking about before prescribing these medications. And you mentioned it as asking, have you had any bariatric procedures? I know with NSAIDs, I ask about diabetes, renal disease. This should be on the list as well.
Definitely.
Our patients may not offer up that surgical history or even know to tell us. So the onus is on us as providers to ask these questions. I'm going to throw steroids in there too. It's like NSAID's partner in crime. And we have a lot of attention on steroid stewardship. We already know that these medications have some significant harms associated with them in our general patient population. Now let's throw the bariatric patient into the mix. This is also a huge risk for those marginal ulcers. So again, a lot of urgent care clinicians, probably more than we would like, are reaching for those steroids as a choice. And we're going to be imparting a lot more harm than good in many of these patients. So my bottom line would be avoidance of any and all NSAIDs and steroids, frankly, unless you really have a significant clinical rationale to utilize them. I would not be utilizing them in the bariatric patient. We need to ask about that surgical history.
Yeah. And so with the steroids, there are some reasons why you would need to give it, like somebody with asthma or COPD or something like that.
Right.
And if you absolutely have to give it, lowest dose, shortest course possible, and with some sort of stomach protection, because these are just as bad. I've had a lot of people that have said, well, I can't give them NSAIDs, so I'll just give them steroids. It's like, no, these are equally as terrible on someone's stomach, even if they haven't had a gastric surgery. So be very careful about it. You're preaching to the choir here with the steroids. I live in the South. This stuff is like water around here. They give it to everybody. And steroids are not benign. We really need to do better with our steroid stewardship.
Yeah. You can see several scenarios where people could get on NSAIDs after gastric bypass. I think it's hard to be careful for years and years. And even patients' understanding of what an NSAID is might kind of not be perfect, right? If a clinician doesn't know that they've had that surgery, and like you said, a lot of the things we see people for are painful, and an NSAID is our reflexive prescription for that, and a person can get on it for that reason. Heck, these are over the counter, and the patient might not understand that those are NSAIDs. And then I find people are confused between acetaminophen and ibuprofen, let's say, naproxen. People typically understand that. But a lot of people mix up ibuprofen and acetaminophen, I find.
Absolutely.
And so there's your problem, unfortunately.
Yeah. Honestly, if you don't take home anything from this podcast, this should be your big take home. Do not give NSAIDs to people that have had weight loss surgery.
There you go.
And probably not steroids either, unless you absolutely have to.
Yeah. So we can treat some of these complications, right? Nausea, some vomiting, some pain. And you mentioned a leak being an immediate referral. to the ED. But what else should perk up our ears? And it's going to be, hey, this person's got to get out of here and get to the ER.
I will say it every time, abnormal vital signs should really prompt you to consider and offer immediate ED referral. Any abnormal sign in this patient population isn't just noise you explain away. First and foremost, sure, recheck them, but don't
Mhm.
anchor on an easy explanation. If it's still abnormal, there is a very low threshold here to get these patients referred over to the ED. So elevated temperature or fever greater than 38 degrees Celsius. That heart rate we talked about, greater than 110 beats per minute. Hypotension, tachypnea, hypoxia. Anybody with new onset or concerning abdominal pain complaints, persistent vomiting, bleeding, severe pain. This patient population, very low threshold to refer further for imaging, laboratory evaluation, and ultimately potential surgical consultation.
Definitely. Do you even want to
Yeah.
try? Maybe give them a little fluids, maybe give them a little ondansetron. Probably not, right? Once you've gotten all those red flags, you're out of here.
I'd feel better if I picked up the phone and called the surgeon and really talked to them. And I feel like the art of picking up the phone and talking to folks is lost, but I'm still a firm believer in talking to their surgeon if they're available
Yeah.
to really, if they were to go home, there's a really good plan in place. They know about them and we're discussing it. But most of the time, these folks require a referral.
Yeah.
Yeah.
Reliable patient, good follow up, which also is becoming a lot less common to have that ability to ensure follow up and acknowledge that the patient is going to take you seriously if you tell them, here's your things that go wrong. If they go wrong, make sure you go to the hospital or emergency room or call your surgeon or whatever. A lot of patients nowadays, I find, think that they can't bother their surgeons or their primary care doctors after hours. I don't know why they think that. There's an on-call, there's somebody that you can talk to. But most people think once that door is closed that now they're not allowed to bother their doctors. I guess they bother them on the email, but not in person anymore. So any patients out there that are listening to this, you can call your doctor.
It's true. I have found, at least for myself, that a lot of these bariatric surgeons, they're very involved with their patients, even years later. When
Yeah.
you call, they're very involved and they really want to do the right thing and take good care of these patients. So it's worth, I would say, picking up that phone and having the conversation.
Yeah, I found that too. The only problem is now people move around so much and if people have had surgery a few years out, they may have moved or gone somewhere else. Or my particular favorite is medical tourism. And
Yeah.
I've seen a lot of that when I used to live in Rochester and now here in Florida. I live in an area where we have a lot of tourists or we have a lot of people that have come from other places and didn't live here originally or have even moved here from other countries or are doing it as tourism. I live in Central Florida. We see a lot of people that go to Miami, which you wouldn't think is really tourism. But, when it's 3 hours away and you have a complication, you can't just go visit your doctor when it's 3.5 hours away and you're sick. I find that really increases complications and the complexity of these patients, a fair amount. Have you had any experience with that?
Yeah, and I think it's estimated about 2% of bariatric surgeries are performed worldwide. So it's very common that we may find this, that patients are seeking care in other countries. It's really about economics and having a lower procedural costs. But with this, when they come home and potentially have complications, we don't have the records. We have no follow-up relationship. It's going to be a little more difficult, certainly, to pick up that phone and call someone, and the potential for higher complication rates as well. So we have to be cognizant that this is a reality, but of course, we're going to approach the patients in the same manner, really have that low index of suspicion and get them the best care that we can.
Yeah, I had a patient once who came in. She had the lap band done in Mexico. The reason being is at the time in the United States, you had to be 100 pounds overweight to get the surgery, but in
Mhm.
Mexico, they were allowing 50. So she went to Mexico and they applied the bands, but they didn't put any fluid in the chamber. She came back home to the United States saying, I need my lap band inflated. And there was not a gastric surgeon or a bariatric surgeon anywhere in the area that was willing to take her on. I felt like saying, didn't you check or straighten this out before you went and had that surgery? She was adamant that I do this in urgent care. And I'm like, I'm sorry, I have no idea how to do this. I also had a lady that came in that wanted me to deflate it in urgent care. And I'm like, Sorry, she's,
Yeah.
but you can feel it. It's right here under the skin. I'm like, sorry, not an urgent care job. Do you have any stories of anything that you've seen in urgent care related to this that were atypical?
As far as in the urgent care, no. I certainly have managed some patients in the ED, and it is, I would say, a tough sell to the on-call surgeon who essentially says, hey, this isn't my patient, or why are they here? And it really comes down to right now, we just got to take care of the patient. They're not flying into Mexico tonight to get this taken care of, but rather drove in here today. So, yes, some ownership questions at times, but eventually everybody knows we just got to take care of this patient to the best of our ability. And yeah, it is
Yeah.
hard when they were somewhere else.
Fortunately, in urgent care, we always have the ability to say, we can't take care of you. Sorry, I guess you have to go to the emergency room, which sometimes it feels like a dump. But in this
Mhm.
case, if it is someone that has some serious illnesses or some serious complications going on, that's absolutely necessary to send them to the hospital.
Yeah.
My husband's an ER doc. I used to be an ER doc. And sometimes I feel like I should call and apologize when, it's something that probably shouldn't be going there. But like in this case, you don't really have a choice. What are you going to do? You have somebody that's got a problem. They really need to be taken care of. So you really need to do that.
Yeah.
Joe, is there anybody you've seen related to this?
My experience is very variable. There's just a whole range. There could be absolutely nothing wrong related to their gastric bypass, or it could be an internal hernia with a closed loop obstruction. It's just that peeling back the layers of the onion every time, because you could have just seen somebody with something else, and then this person has a simple gastroenteritis, or maybe it's more severe. So you just have to be diligent and start from square one with each patient, go through and ask the right questions, do the physical exam, and almost all of them end up getting CT'd. And even then, like you said, there's occasionally times where there are things that either the radiologist hedges on, or I'm looking at the scan and I'm like, this doesn't look right. And we call the surgeon. And in dealing with this, sometimes our surgeons are better at interpreting the scan than the radiologist is. So knowing all of those things just with experience, I think, is what helps you manage the patients better.
Do you want to do the one thing I learned from this article that either surprised me or was new to me? For me, it was kind of internal hernias. I knew about them, but
Yeah.
I didn't know that the CTs could be potentially negative. So that was a bit new to me, and probably not something that I'm going to be diagnosing in urgent care, but definitely something that I should be more aware of.
Yeah, I think if they had a hernia with an obstruction, I think the sensitivity is a little bit better, but you can have that loop of bowel slip through the mesenteric rent that's been created from them rearranging stuff, and you won't be able to tell just based on the orientation of the bowel. So the person could have symptoms that come and go from that, from what I understand, and until it becomes more critical, that's when your CT goes up. But it's always nice to know that something like that's going on at an earlier stage, so you
Yeah.
can fix it before it becomes critical.
Definitely.
I actually didn't know that anastomotic ulcers are now called marginal ulcers. I always learned them as anastomotic ulcers, but anyway,
Interesting.
sounds cool. We do a fair amount of bariatric surgery at our hospital, and several surgeons are pretty active, do several a month. And they're always, for their patients, very receptive to calling them. Even years later, somebody can come in and they remember their names and everything. It's really kind of interesting. They differ in their approach. One of them thinks anything could possibly be wrong, and then the other one is sort of like, yeah, they'll be okay. And they're
Yeah.
usually right. But again, you just have to start from square one with all these patients and sort through the possibilities, work them up. And then if you don't find anything, and you discharge them with good return precautions and follow up if you can
Absolutely.
arrange it, or have them come back to the ER if they're not getting any better. The other thing about return precautions is not only come back if this happened, but come back if you're not better in 12 to 24 hours, or somebody should see you again. An expectation of improvement, if it's something that's benign and self-limiting, that's also an important part of return precautions too. We can substitute for follow-up.
Definitely. Anything else you want to add, Melissa?
No, I would comment that approach this patient population with care and caution. Consider worst case scenario. Always look at those vitals, recheck them. Don't wish them away or hang your hat on a benign diagnosis. And certainly have a low threshold to refer these folks to the ED for labs and advanced imaging. Certainly anyone with new onset abdominal complaints.
Definitely. Definitely.
Yeah.
Good advice. Absolutely good
Mhm.
advice. Well, I want to thank you for joining us here.
It's a pleasure. I appreciate you having me.
Yeah, thank you.
We appreciate all you do for evidence-based urgent care. What do we got next time?
I don't know. You tell me. You're the editor-in-chief. What's in the pipeline?
I know we have testicular problems coming down the pipeline. We also have transgender and gender diverse, which is going to be interesting because it doesn't really fit our format the way we usually like to have it fit, but very interesting. And the person that wrote it is very knowledgeable about these sorts of things. And so was the peer reviewer. And they went back and forth a few times and really improved the article to the point that I think it's going to be a really good article for us to discuss. We got sinusitis coming. We've got knee pain coming. We got pediatric asthma coming. So a bunch of good things to look forward to in the future. So
Great. Good deal.
great.
Some bread and butter and some cutting edge stuff. That's wonderful.
Absolutely. Absolutely.
Yeah.
Well, thanks everybody for listening.
Thanks, everybody. Thanks, Tracy. Thanks, Melissa.
Everybody have a good night, day, whatever time you're listening. See you next month.
Take care. Bye-bye.
Bye. I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site. That's evmedicine.net to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.